Okay, well, thanks for the opportunity to speak here, and thanks for sticking around on this late in the day. I guess I'll use this guy. So I was initially asked to talk about why not to treat these large vessel occlusions with low NIH stroke scales. And I have no financial disclosures, but clinically, I do treat a lot of these low NIH stroke scale patients with thrombectomies. We all know that large vessel occlusions have poor morbidity, poor mortality, poor outcome if we leave them alone. We know that we have more and more data now that these patients that maybe present with low NIH stroke scales are getting worse and worse with observation. A few years ago when I started doing this, I think if we had a low NIH stroke scale patient with a large vessel occlusion, more often than not, we would watch them and kind of maybe sit them up or something like that, and we would be less aggressive with them. And as we now know that the outcomes may not be so good. We now have a lot of more and more data that these patients with these large vessel occlusions that present with low NIH stroke scales actually progress to more significant symptoms. We know that patients with low NIH stroke scales often have large vessel occlusion. There's a lot of data now that even NIH stroke scale of 7, 8, 9 are very good predictors of a large vessel occlusion. And we also know that we have more and more data that the more patients that we treat with these low NIH stroke scales with thrombectomy are doing better and better. This is a recent paper in the JNIS showing that they're kind of recommending that if you have an NIH stroke scale less than 6, but you have disabling symptoms with a large vessel occlusion, they recommend treating them. Again, because large vessel occlusions primarily, regardless of symptoms, tend to have a poor outcome. So what do we do? So obviously it's very easy if you have a high NIH stroke scale. We know what to do with those patients. With a low NIH stroke scale and a large vessel occlusion, it can be a little bit trickier, and some of the prior talks have kind of commented on this. Who should we treat? When should we treat them? What are our criteria for treating these patients? Again, there's a difference between low NIH stroke scale and mild symptoms, and I think this is an important point that I'll talk about in a minute, but I think and low NIH stroke scale does not equal mild symptoms. What should we consider when treating these patients? And again, sort of, if we're going to talk about this, what is a low NIH stroke scale and what is large vessel occlusion in these patients with low NIH stroke scales? Obviously, a large vessel occlusion is very different when you have an M1 and an NIH stroke scale of 20, but if your NIH stroke scale is 5, 4, 3, or 2, what are the vessels that we should be going after? And so I think one important message is a better question maybe than what is a low NIH stroke scale? What are the symptoms disabling or not? And I think we find that when I take telestroke at multiple hospitals, in the beginning we were very hung up on what the NIH stroke scale was. Was it a 2? Was it a 6? Was it a 10? Obviously if it's a 20 or something like that, it's very easy. And what I found is that it's much easier just to ask the ER physician or a non-stroke neurologist, are the symptoms disabling or not? They're much more comfortable answering that question than, is the stroke scale a 4 or 6? If the symptoms are disabling, they're very comfortable making recommendations based on it, including TPA, not just thrombectomy. So for these patients, should we be talking about NIH stroke scale of less than 6 based on those prior trials? We know that there was some treatment effect for these patients with low NIH stroke scales in the subgroup analyses. But what is the definition? What is a good idea of what we should be treating or not treating? What is a large vessel occlusion? In all these different trials, everyone has they have similar but not necessarily the same definition of a large vessel occlusion. We heard some of the prior speakers talking about M3 branches and A2 and A3 branches. What are the branches that we should be treating? Obviously, if we have a carotid terminus occlusion and a low NIH stroke scale, I think that might be more likely to decompensate later and somebody we should treat versus a right M2. So I think we take into account the different vessels that are occluded. Obviously, a basilar occlusion we tend to treat, even though they weren't really studied in trials. Proximal PCA occlusions, I don't do a lot of PCA thrombectomies, but for example, we did one a couple weeks ago that came and looked like a basilar. We did the thrombectomy because it was a proximal PCA, and it turned out they had an artery percheron occlusion, and they ended up doing well with the thrombectomy. What about we get a lot of these patients now? They come in with a carotid terminus occlusion, but there's no intracranial occlusion. Should we be chasing those patients? The vessels are open up in the head, but the carotid terminus is occluded. Obviously, they have some kind of collateral circulation. Should we be treating those patients? And then again, not all large vessel occlusions are equal. I'm much more likely to treat a left M2 occlusion with low symptoms than a right M2 occlusion. Just we all know the natural history of those patients. Right MCA patients just tend to do better than left MCA occlusions. So when we think about, why do these patients have these mild symptoms despite the large vessel occlusion? And it's usually due to good collateral flow. If they have a chronic occlusion or stenosis, they might have developed good collaterals prior to their acute symptoms, and they have good collateral flow. And can we predict those who are going to deteriorate? And I think this is an important question, and it's difficult to predict these patients. I think there's a lot of reasons for patients to decompensate with an acute occlusion, and acutely, I think the collateral failure is probably the most likely cause of acute decompensation of these patients. What causes acute collateral failure? And this is something that if you could accurately predict with non-invasive imaging, I think you'd be doing pretty well. And we try to, again, this is something we think about: are these patients going to decompensate while we're watching them? If we're not going to treat them up front. And so what do we think is causing the collateral failure? Is it autoregulatory failure? Is it blood pressure changes? Is it this Steele syndrome where blood is shunted away from the infarct towards a viable tissue, worsening the ischemia? And so I think, trying to bring this home, why I would treat them or why I wouldn't treat them, the way I think about patients is, are they elderly? And again, not all elderly patients are the same. I've treated 90-some-year-old patients that play bridge and play golf and play out with their grandkids, and I've not treated 60-year-old patients that are bedbound and nursing home patients. So I think age might be something to consider. What is their baseline modified Rankin? And I think we all sort of think about this. If their modified Rankin is maybe 2 or 3, or if they're bedbound, or they're already if they're already in a nursing home without any real functional capabilities, I think maybe not treat these patients. Significant medical comorbidities. I think one that I often think about is I ask about cognitive dysfunction. If they're demented, my chance of treatment goes way down. Are the symptoms disabling or not? And I think this is one of the most important things. And again, if the disabling is different from person to person, and I remember one of the earlier patients I had, I was told by the ER they had an anti-stroke scale of 2, and then found out that they were a 50-year-old surgeon. Obviously, that's a disabling deficit for that person, whereas an anti-stroke scale of 2 for numbness is not so disabling. Improving or resolved symptoms. Again, I think something we can think about. I had a recent patient who was 85, had an MCA occlusion. We transferred, by the time our transfer team got to the outside hospital, her anti-stroke scale was down to 0. We transferred her anyway. We brought her over to our hospital, and we watched her there. And in the end, after several, we ended up not treating her. Follow-up imaging demonstrated she still had the MCA occlusion, but the only deficits we could find was somebody that spoke Armenian and actually spoke to her in her native language, and found that she had some very mild word-finding difficulties. So I think improving symptoms is obviously something we might not necessarily treat. Which vessels occluded? We talked about that. It might be a little bit more aggressive with a left-sided lesion versus a right-sided lesion. Chronic occlusions, obviously I'm not very excited about trying to get through a chronic stenosis. I think the chance of having to do some sort of intracranial angioplasty and stenting goes up. What's the baseline imaging? And is there no perfusion lesion? If somebody had low symptoms but an MCA occlusion, but the perfusion imaging looked pretty good, I might be less inclined to treat that patient. And so what do I think about? Again, I think about everyone gets TPA. I haven't changed that. I think about once a month we have a large vessel occlusion. We give TPA to, and by the time we get to the angio suite, the vessel is now open, so everyone gets TPA. We'll observe them, and frequently all I really do is sit them up at 90 degrees for 15, 20, 30 minutes and see how they do. And a lot of times I'll take these patients for a diagnostic angio. The morning it'll show, is there recanalization with TPA? Is there a stenosis? Is it a chronic occlusion? Is there good collateral circulation? I think any of those may help us decide if we're going to treat these patients or not. So sorry I'm a little bit over time, so I'll stop there. Thanks.